Good evening, everyone. I'm Jackie Walker, CEO of Pacific Edge Diagnostics USA, and I'd like to welcome you to the Cxbladder virtual dinner program. Thank you for joining us this evening. We're very excited to have a group of distinguished urologists present their case studies on where they found clinical utility for Cxbladder within their practices. Although Cxbladder may be new to some of you, we're not new to the United States market. We've been offering Cxbladder in the US since 2013, and we run all of our Cxbladder samples at our proprietary CAP-accredited, New York-approved laboratory in Hershey, Pennsylvania. Since launch, we've provided over 80,000 patient test results for over 2,000 US clinicians. While COVID has been a challenge for us and everyone, we're thankful that we've been able to achieve some key milestones over the last 2 years. In April of 2020, we launched the Cxbladder Patient InHome Sampling Program to support patient care and our urology clinicians during COVID-19 and beyond. In July of 2020, we received Medicare coverage for Cxbladder, which is really important because so many of our patients are over the age of 65. And in November of 2020, we completed our agreement with Kaiser Permanente for use of Cxbladder within their healthcare system. And while we're proud of these accomplishments, the thing we take most pride in is being able to help clinicians and patients with the diagnosis and management of bladder cancer on a daily basis. So we're glad that you could join us here this evening to learn more about that. Now I'd like to turn the program over to our distinguished faculty of the virtual dinner program, led by our moderator, Dr. Sia Danishman. Thank you for attending the program. We are delighted that you could be with us to kick off the new year in 2022.
Okay. Hi, everyone. I hope you can see me and hear me fine. Someone can give me a thumbs up or something. We have a great hour ahead of us. We're going to hear from some of my great colleagues here. We're going to start off with Dr. Scarpato, an associate professor of urology, and she's the urology residency program director, as well as the vice chair of education at Vanderbilt University. I've had the pleasure of being on the webcast before with her, so we look forward to her overview of Cxbladder. Then we'll go to Dr. Goldfisher. Evan Goldfisher is an assistant professor of urology at New York Medical College, director of research, and works at the Premier Medical Group in Hudson Valley. And he'll be discussing the adjudication of atypical cytology in bladder cancer, something we see somewhat often. So Dr. Murray will be next, assistant professor of urology at the University of Missouri, medical director of urologic oncology, and she'll be presenting on the utility of in-home sampling with Cxbladder, something that's become more important during the COVID era. And then I think we'll finish off with Dr. Spekianos, my good friend and colleague, assistant professor of urologic oncology in the Department of Urology at the Icahn School of Medicine in Mount Sinai in New York. And he'll talk about CX Monitor in surveillance of bladder cancer. I'll forgot to introduce myself. I'm Sia Danishman. I'm professor of urology at USC. I'm director of clinical research in the fellowship program, I've been using Cxbladder for a number of years and really have found good utility in certain areas within bladder cancer. I have great interest in bladder cancer research for both non-muscle invasive as well as muscle invasive bladder cancer. So with that, I'll go ahead and hand over the slides to Dr. Scarpato, who'll give us a good overview of Cxbladder.
Welcome to the Cxbladder virtual dinner program. My name is Kristen Scarpato. I'm a urologic oncologist at Vanderbilt University Medical Center. We will review several specific case examples for Cxbladder this evening. But first, I'd like to start with a broad overview of Cxbladder. I think it's important to start with the economics of bladder cancer. And prior to diving into the economics, we have to think a little bit about epidemiology. Approximately 11 million patients will present with hematuria annually. This translates into over 4 million cystoscopies. As we know, the American Cancer Society puts forth estimates of incident cancer in the United States each year. And this year, over 81,000 new patients will be diagnosed with bladder cancer. Said another way, 1 in 42 people will be diagnosed with bladder cancer in their lifetime. This translates into bladder cancer being one of the most costly cancers to manage. The direct costs, so by direct costs, I am not including things like indirect costs of patient suffering or lost productivity. The direct costs in 2010 were estimated to be about $4 billion a year to manage urothelial carcinoma. The 2020 estimates show that number rises to almost $5 billion per year. That's pre-COVID numbers. Looking at the individual patients, the average lifetime cost is expected to exceed over $220,000. So based on the direct costs alone, again, bladder cancer is one of the costliest cancers to manage. And this is related to the well-established high recurrence rate, the low mortality rate for most urothelial carcinomas, and then the significant cost associated with disease surveillance. Cxbladder has been commercially available in the United States since 2013. This test is an objective genomic urine-based test, and is optimized to provide diagnostic clarity covering the entire continuum from hematuria through patients with urothelial carcinoma. This is a very helpful schematic, and we'll start at the bottom and work our way up. Within the hematuria pathway, there are 2 Cxbladder tests. There's Cxbladder Triage and Cxbladder Detect. Cxbladder Triage is optimized to identify low-risk hematuria patients, for example, patients with asymptomatic microscopic hematuria who have a low probability of urothelial carcinoma and may not require a full workup. You can see here a very favorable sensitivity of 95% with a high negative predictive value, 98.5%. Cxbladder Detect offers high sensitivity and high specificity, as you see here, and serves as an objective adjunct to cystoscopy. As you'll see later tonight, Cxbladder Detect can add objective diagnostic clarity for hematuria patients when you have an atypical cytology or you have discrepant results. And then finally, at the top of the schematic here, you see Cxbladder Monitor. This is a product that's to be used for patients who have a history of a diagnosis of urothelial carcinoma and are undergoing surveillance. With a high sensitivity and a high negative predictive value, Cxbladder Monitor can identify patients with a low probability of recurrence to help extend intervals between cystoscopy for appropriate patients and also increase overall compliance within the surveillance protocol. Without getting into the specifics, Cxbladder has been extensively studied, and the validity of Cxbladder Detect and Triage within the hematuria pathway has been demonstrated in multiple high-regarded peer-reviewed publications, as you can see here, Journal of Urology, BMC Urology, and European Urology. Similarly, Cxbladder Monitor has been extensively studied within the surveillance pathway, and the validity of Cxbladder Monitor has been demonstrated in multiple peer-reviewed publications, as shown here. One of the case studies that you'll hear about tonight focuses on the use of Cxbladder in the adjudication of atypical cytology. The objective of this study is to evaluate the performance of Cxbladder and urine cytology and Cxbladder's adjudication of atypical cytology and equivocal cystoscopy. In this study, 852 patients had both Cxbladder results and local cytology results available. 18% of those patients had atypical cytology by their local pathologists. Cxbladder correctly adjudicated 153, so all results, all atypical results. There were no false negatives. Furthermore, 47 of these 153 atypical cytology results were correctly ruled out by Cxbladder. Within this population, 14 samples were atypical and the patient had an equivocal cystoscopy, and Cxbladder was able to correctly adjudicate all of those, including 2 samples where the patient had invasive urothelial carcinoma and 1 patient who had high-grade CIS. We can conclude from this study that Cxbladder correctly adjudicates patients diagnosed with urothelial carcinoma among those with atypical cytology and an equivocal cystoscopy. And Cxbladder demonstrated superior performance when compared to cytology for accurately identifying patients who do not have urothelial carcinoma. Another case study that we'll hear about tonight focuses on the use of Cxbladder monitor in the surveillance pathway. This was published in 2020 in BMC Urology. And here is a quick summary. This is a real-world use study demonstrating the clinical utility of Cxbladder monitor in the surveillance of patients, again, with a known diagnosis of bladder cancer. These patients initially were risk stratified as high risk or low risk based on their history of urothelial carcinoma. And then urine was evaluated using Cxbladder monitor. And patients were then surveyed based on the results of those two findings. It's important to note that clinical utility of Cxbladder monitor in this study was based on the number of cystoscopies avoided under the new protocol compared with the former surveillance protocol in which all assessments were by cystoscopy. You can see that Cxbladder monitor accurately ruled out almost 80% of patients who did not have pathology confirmed urothelial carcinoma recurrence. And this was regardless of that initial risk classification as high or low risk. There was 100% sensitivity of Cxbladder monitor, so not a single tumor was missed. And during the longitudinal evaluation, 35 months, Cxbladder monitor did not miss any high-grade tumors, and no patients progressed either to muscle-invasive disease or to metastatic disease, and there was no cancer-specific mortality. So we can conclude from this study that Cxbladder monitor can reduce the cystoscopic burden in certain patients, can obviate the need for risk stratification based on clinical parameters, and finally, can allow us to identify patients who are at higher risk of recurrence regardless of when they were originally diagnosed with urothelial carcinoma. Another great benefit of the utility of Cxbladder that became extremely helpful during the COVID-19 pandemic was the use of Cxbladder in-home sampling. This allowed patients to undergo Cxbladder testing all from the comfort of the patient's own home. What we're able to see with Cxbladder in-home sampling is improved compliance for non-muscle invasive bladder cancer patients who are undergoing monitoring. This also translated into improved clinic and procedure workflow. And this is because patients who are identified as low probability were able to delay action. And then finally, Cxbladder in-home sampling adds clarity and clarifies equivocal hematuria workups. So this is just a brief overview of our program. I know you will enjoy it, and I look forward to answering any questions. Thank you.
Great, Kristen. Thank you so much. Yeah, that was a great overview of the test, and I'm sure many of my colleagues and people who see this for the first time ask, when do you actually get the urine? Can I get it from the scope as I put the scope in? Because sometimes those decisions are made after you're doing the cystoscopy of whether or not you should be sending the test. So can you tell us in general where we're supposed to get the urine from?
Yes, thanks, Sia. Appreciate the introduction. Part of our workflow, we collect the urine generally before the patient has undergone the cystoscopy, and that's just sort of protocol when patients come into our clinic. We're urologists, we always get a urine sample, and you really want to avoid getting the urine from the scope because there can be some sort of interference from the saline in terms of the test results or any of the gel that you're using, or any inflammation or trauma from the passage of the scope. So ideally, you're going to collect the urine beforehand and send that off for your Cxbladder.
Yeah, exactly. I mean, as you said, we're urologists, so we always have urine sort of sitting around. We actually do flexible blue light cystoscopy in the office, so we always have urine from the catheterized specimen before the cyst view goes in. So that's always sitting on the side. I often make the decision in between during the procedure, when I see something, atypical or not completely normal, then I would want that test to go out along with cytology. Do you send cytology on every case, or is it do you just send it on specific cases?
Yeah, I generally don't send it on every case. I think we know that cytology has some shortcomings, and it's really not indicated for all patients. But certainly if it's a patient who has a high risk for either recurrence or has significant symptoms and I'm concerned about possible CIS, then I'll send a cytology. If it's a patient that I've been monitoring with cytology and their initial diagnosis, they had a positive cytology, I will, but certainly not for a patient who is low risk. I don't send cytology.
Yeah, same. I think we follow pretty much the same rules. The other question that comes up often, you mentioned that detect and monitor, and some people think these are 3 different tests. Can you explain? Is this all one test or 3 different tests?
Well, these are all genomic tests to analyze the urine, but they're really utilized for different patient populations. And so, if you're worried about a patient who has a recurrence, then you'd want to use the monitor for that patient population. But for patients in the hematuria pathway, you would consider using triage, particularly if they're a low-risk patient, or for a patient who, you're not sure about their cystoscopy or their cytology is atypical, then obviously you'd want to use the detect. So I think really it's the patient population that you would use each test on that's a little bit different.
Right. Yeah. So it's the genomic test is the same, but the algorithms are different. So you want to pick the right test for the patients to come up with the right sort of sensitivity and specificity for each population, as you said. So let's go to Dr. Goldfischer. We talked a little bit about atypical cytology, and I think this is where you showed that paper from European Urology with Dr. Canetti. This is really where this test performs extremely well, is adjudicating that atypical cytology. So I look forward to Dr. Fisher's talk and then some discussion afterwards.
Hi, everyone. I appreciate everybody tuning in today. We're going to talk about a case study using atypical bladder cytology to illustrate how I use Cxbladder in my practice. For those of you who don't know me, my name is Evan Goldfischer. I'm the Director of Research and co-founding CEO of Premier Medical Group in the Hudson Valley. And I've been using Cxbladder in my practice for quite some time, and my partners have also adapted the test. I hope this serves to kind of synthesize what's already been talked about the test and how it might be incorporated into an office practice. So our agenda over the next few minutes will be to review different clinical scenarios where Cxbladder is appropriate to order, to understand the clinical need for ordering Cxbladder, to discuss how Cxbladder test results impact patient outcomes, and to try and gain some insight and perspectives on clinical utility of Cxbladder test. So this is a real patient who's in my practice right now. He's a 64-year-old male, and he presented with asymptomatic microscopic hematuria. His PSA is 2.64. He has some mild hypertension, dyslipidemia, and BPH, kind of typical 64-year-old in my practice. No family history of kidney, bladder, or prostate cancer. And he takes 1 81 milligram baby aspirin per day, but no other blood thinners. But he does have a significant smoking history, 1 pack of cigarettes per day for about 40 years. So given that history, I performed a CAT scan with and without contrast that was normal. I did a white light cystoscopy, which showed lateral lobe hyperplasia of the prostate, but no bladder tumors. And I sent out a cytology, and I got back a cytology that was atypical. No abnormal cells, but atypical cytology. So given his history of smoking, the microscopic hematuria, I was certainly concerned. Might there be cancer in the bladder that I just couldn't see yet? Should I do a blue light cystoscopy? And should that be ordered as the next step here? Now, for those of you who are doing blue light cystoscopy, you know that the patient has to come in about an hour before the procedure, undergo a bladder catheterization where the medicine is instilled, and then sit in your office for about an hour while the medicine coats the bladder, and then you perform the cystoscopy. So it's really not something you can do on every single patient. It can be disruptive to the flow in the office, does take extra steps, and the patient does have to hang out in an exam room for about an hour. So you want to be responsible and judicious on how you use this technology. So in my case, the choice was do a blue light cystoscopy or have the patient come back in several months for a repeat cytology and see what's going on. Instead, I chose to order a Cxbladder detect test. And as you can see on the screen, it came back rather high. So this was very, very, very concerning to me, given his history that he could have urothelial carcinoma. And I just didn't see it on white light cystoscopy. It wasn't visible yet. And just remember, Cxbladder detect is ordered on a voided urine. They can do it in the office while they're there, or they can do it from their home. The test can be mailed to them. They collect the urine sample and send it back. And during the time of COVID, when patients are trying to reduce their visits to office, this might be a way to go. But anyway, we did the test and came back abnormal. I was concerned, so I did a blue light cystoscopy. And there were several abnormal lesions that were found in the bladder. Biopsies were conducted and cauterized and sent out for pathology. And the outcome was several of the biopsies revealed carcinoma in situ. So I started the patient on an induction course of BCG. And because of the Cxbladder test, I did the blue light cystoscopy, and I found the carcinoma in situ before it was visible on white light cystoscopy, diagnosing him probably several months, if not more, before the lesions would actually be visible. So again, our goal here was to avoid unnecessary blue light cystoscopy and to be respectful and responsible in how we use that technology. I was able to do that by using the Cxbladder detect test, which is simple, accurate, and cost-effective. The results in this case did support the need to conduct the blue light cystoscopy. And as a result, I was able to detect carcinoma in situ earlier, which gives me an opportunity for better patient outcomes. And therefore, I've incorporated the Cxbladder test and the Cxbladder monitor, which is a separate discussion, into my practice. And most of my partners are using the test at this time as well. Thank you very much for tuning in.
Great. Thanks so much, Evan. That's great. That was a great example of how you were able to diagnose this patient early. We know cytology is not great. And one of the questions here from the audience is, do you use this on atypical cytology to avoid random bladder biopsy workup? Can you talk to us about that?
Sure. I do use it on atypical cytology to avoid the random biopsy workup and to avoid doing a blue light on everybody. And I'm slowly starting to replace my use of cytology with the Cxbladder a test. I'm doing it certainly on the monitor now. I'm sending a Cxbladder monitor now instead of the cytology because I think it's more accurate, and we have a paper in the literature now that actually supports that. Great,
right. So your use of cytology then has decreased over time. When are you sending cytology versus CX?
You have to have a certain period of time for the Cxbladder detect and Cxbladder monitor before you can order the test. You can't just order the Cxbladder monitor. You're right, when you're diagnosing, I believe it's a 6-month window before you can actually order the test. So in those cases, I do cytology. And the rare case that it's not covered, and it's usually covered, then I'll do cytology.
Got it. I think one of the concerns is, we have a very high negative predictive value with Cxbladder. The positive predictive value is somewhere in the high 60 to 70% range. For cytology, we have a very high positive predictive value, but our negative predictive value is not so great. So, in some practices, the way I use it is I use both because if we're seeing cancer cells, you're right, almost certainly the CX is also going to be positive, but I haven't quite made that leap yet to just do the CX, but I suppose you're right. The data is there. And we know that cytology just doesn't perform as well as we know. We have plenty of patients. We're looking at tumor, and the cytology comes back negative. And we found that in the blue light study, the phase 3 study of flexible blue light, where all the lesions that we're picking up with blue light, of the 13 lesions that were seen with blue light only, all the cytologies were negative. But they were not positive. So I think the other question is, if you have atypical cytology, does this avoid a trip to the OR? And I think that's certainly the case. I think that's the point. If you have atypical cytology, some feel the need to go to the operating room and do random directed biopsy, especially not every center has access to blue light in order to rule out CIS or something occult. Are you, as a result, doing less random directed biopsies? Are you relying on the CX to tell you if it's negative? It's negative. It's a 98, 99% negative predictive value.
I am relying on the Cxbladder, and I'm also relying on the blue light in combination. So if I have a negative Cxbladder, or even if I have a positive Cxbladder but a negative blue light, I'll probably repeat the cytology or the Cxbladder in 3 months rather than go directly to the OR, especially during COVID times when it's getting harder and harder in the Northeast to get elective OR time for a cystoscopy and bladder biopsy. We're being limited on what we can do.
So we have another question here from the audience. AUA guidelines for evaluation of microhematuria do not recommend cytology or any other urinary marker studies. What triggers the need to go outside the AUA guidelines? And was it smoking history alone or in the face of negative cysto and CT? So what is it that makes us do a CX detect, for instance?
Well, you have to remember the AUA guidelines are just guidelines, and they run several years behind the literature, and they're not updated every year. So it's AUA guidelines, but there are other guidelines as well that are updated a bit more frequently and are a lot more current with the literature.
So here's one more question. That's a great answer, and I completely agree. As the data is available, the guidelines then rely on the data to get updated. And I'm on the AUA guidelines for bladder cancer, so for non-muscle invasive bladder cancer. So hypothetically, if you would have seen nothing on blue light cystoscopy, would you plan for retrogrades and get urine barbotage from the upper tract to send cytology or Cxbladder test?
No, I would have gone to do retrograde and selective cytology and even possible flexible ureteroscopy, having a direct look. Absolutely.
Okay, great. All right, let's move on to the next presentation, and we'll have some other more discussion after that. Dr. Murray.
Thanks so much for having me here today. I'm Katie Murray. I'm a urologic oncologist at the University of Missouri, and I have the pleasure to talk about Cxbladder in a case study discussion of patients that we see on a regular basis and the utility of an in-home sampling kit for utilization of Cxbladder monitor. So as we go through this, we're going to review things that come up in our regular practice, a review of different clinical scenarios where Cxbladder may be appropriate, understand the implications and clinical needs for ordering these tests, discuss how these results may ultimately impact our patient outcomes and satisfaction, and then also gain insights from ourselves as healthcare providers on the utility of this test in treating our patients. So let's look at a typical scenario, right? We all have these patients in our clinic. Here I'm just presenting a story of a 66-year-old female who is very well known to me, who I've seen for several years, who has a recurrent history of low-grade TA urothelial cell carcinoma. Of course, she lives 2 hours away from my clinic and has a lot of social implications. And part of that is taking care of her 13-year-old grandson, who does require nearly 24-hour care, in which she's the primary caregiver. She is a former smoker. She quit about 15 years ago. Scheduling to see me regularly. Her last recurrence of low-grade bladder cancer was 9 months prior. She's been treated previously with multiple TURBTs with immediate intravesical gemcitabine instillation, and returns to clinic on average about every 6 months for a follow-up cystoscopy. Right, this is just one scenario. We all have so many scenarios of patients that we see in these exact situations, right? And what is that we're actually seeing? We're seeing these challenges for patients to come and see us for these routine visits that we've always felt are very necessary to look for recurrences of bladder cancer, right? What other challenges are there? We're all very busy clinicians. We have so many patients to be seen on any particular day. There's social situations of our patients to physically get in to see us. There's travel implications. There's caregiver implications. What kind of, do people have to take off work, to come to their visit? Does it, for this lady, for instance, it impacts her grandson. There's weather situations where patients sometimes cannot travel to come see us during weather. And then, of course, right, we're in 2021, 2022 here, and we're talking about a pandemic, COVID-19, things like children are not in their school sessions. And that forced us to reassess some of the things we do and look at weighing risks and benefits of in-person visits for patients with these recurrent bladder cancers, really thinking about our low-grade patients, but maybe even some of our high-grade individuals. Right, so reasons for ordering a test like this would be based on this challenge. This was the question that we were all presented with. Is it imperative? Does this person really need to come for an in-person visit and a cystoscopy as scheduled? Maybe we should explore something else to see if we can delay cystoscopies, or maybe we can skip some of these in-person visits and or extend the intervals between these in-person visits and cystos in clinic. Right, so what does a Cxbladder in-home sampling kit look like, and what does that flow look like? So, what is our responsibility? Ultimately, our responsibility for doing this is identifying patients, right? So identify the patients that could potentially seek advantage from having one of these tests, inform the patient that we are going to send this out to them. It's going to be shipped to their home. And then we complete the ordering forms that get sent to Pacific Edge via fax, via email, electronic share, just talking about the patient's history. What happens on the behalf of the company, Pacific Edge, then their responsibility is they ship out this in-home sampling kit to the patient that gives strict instructions on how to collect their sample at home, informs the patient of any financial responsibilities with this test. They physically run the Cxbladder monitor test and then deliver those test results back to us, to our clinic, within 7 business days, right? Then what happens? We get those test results back, patient follow-up and clinic follow-up, and you can determine whether that's going to happen in an in-person visit. Are you going to delay a cystoscopy? Are you going to do it telehealth, telemedicine, or just a phone consultation visit with the patient? So what does that look like? This test request form for Cxbladder, right? It comes in 3 different formats, but what I'm talking about here is Cxbladder Monitor. We're talking about collection dates, which really on this particular is an in-home target sample date. So you're giving the patient a time frame or a goal time date of when you want this test to occur. And then, of course, we have a diagnosis code, an ICD-10 for this patient, for instance, is a history of bladder cancer. So over the past year, I had a the pleasure of treating, several patients, of course, with bladder cancer, as so many urologists do. And I explored using this in-home sampling test for my patients. And I used it 13 patients, was able to obtain results on 11 patients, and delayed cystoscopy on several patients, in both patients with positive and negative tests, with ultimately positive results from delaying some visits and delaying exposure to coming into the hospital with COVID-19. So during this time frame of using this, again, 13 patients had an at-home test. 2 patients did not obtain results due to excessive inflammation in their initial urine specimen they collected at home. Of those remaining 11 patients with results, 9 patients had results, and we proceeded to follow up with a cystoscopy within an 8-month time frame after. There were no false negative results based on this gold standard cystoscopy sometime within that 8-month time frame. Of those 11 patients, 5 delayed in-person appointments and delayed that cystoscopy for a mean of about 6 months. With 3 patients avoiding an inpatient visit altogether until at least November of 2020. So, this was something that we thought that looked very positive, of application where this test is something, that is somewhat familiar to urologists and patients as far as doing an in-home collection of urine and sending it back. And so we also asked our patients, how did this work? How well did you, were the instructions on getting this test completed? And when we asked all of these patients, 69% of patients rated the test, as saying 2 out of 5, 89% of them stating they would definitely consider using this test again, and it was not implication in their life, right? So how difficult was it from 1 to 5? 5 being the most difficult. No patient said that getting this urine collection at home was very difficult. A majority of those patients said that it was very undifficult, or the least amount of difficulty. And then, would you ever use it again? A majority of patients that responded said, yes, we would do the Cxbladder monitor test again in the future. Because the implications of that were not too difficult. And therefore, this, I think, is a great opportunity for us to really be thinking and exploring for our patients. And maybe one of the positives that has come out of a pandemic, and reassess what we're doing. Are there tests out there, such as Cxbladder monitor, that we can do on our patients, that they can do from their home? We can review the tests, and it can change their care without harming them from an oncologic standpoint in cancer. And that's all I have for you today.
Great, Katie, thank you so much. That's great. And we're seeing the benefits of that in-home use as well. Especially during the pandemic, but also patients who, like you said, have to travel far to get to our clinic. On occasion, will call in and say, well, I just can't get in. Can we reschedule? And we'll look at their history and offer them a in-home Cxbladder test to kind of bridge them over to the next cystoscopy. So I see the satisfaction rates in your patients has been high. How has this impacted your practice overall? Or do you continue to use it, and are patients liking it?
Yeah, so I think, obviously I have some small numbers here in just our few patients that we started during the pandemic, but I have continued, on select patients, especially those low-grade patients that do travel a distance to come and see me, and trying to kind of alternate it, on appointments, a Cxbladder monitor at home, in-home test, and then come to see me at the next visit, pending that's a negative test. I do think patients like it. Interestingly, several of the patients who I gave it to initially at the time when the pandemic was, I want to say, in the heat of it, although here we are in 2022, kind of repeating that in the heat of it. But, and those patients, ask me about it continually, oh, can I just do that urine test at home? Do I have to do this ever again? And I say, I'm not going to let you off that easy, right? I still need to, the gold standard is looking in your bladder, and I need to do that, but can we stretch that out? Probably so.
Yeah, and I think it's ripe for some studies in the future to see, particularly the lower risk patients, whether we can actually use these biomarker tests, this biomarker test to delay the intervals. Do we really need to do that many cystoscopies on the low risk patients? I think it'll be a great studies in the future. So this sounds like it's pretty much streamlined into your practice. Then have other providers in your practice started using this test?
So I would like to say yes, but that's not been the case. I'm the only person in my practice who has adopted it. I've brought it up many times at our conferences and all, and said, hey, this is what we're doing, and been able to delay these people. Yet just harder to, for those people. I think it's that fear of doing something the first time, right? We all do that in anything new that's out there. And this is right. Stretching a bit, right? It's not a urine test in your clinic. It's at home. And so it does push us a little bit, but no better time to do it than when patients don't want to come to see us in clinic for their own safety and for the safety of others.
Right, sure, and the more data we see, the more comfortable our colleagues will become. So let's hear the last little bit of presentation from Dr. Spicianos, and then we'll have a discussion at the end.
Hello, my name is John Spicianos. I'm a urologist at the Icahn School of Medicine at Mount Sinai. Today, I'm going to discuss a case of Cxbladder in a Cxbladder monitor and surveillance of a patient with BCG treatment. The objectives of this discussion are going to be to review different clinical scenarios where Cxbladder is appropriate, to understand clinical need for ordering Cxbladder, to discuss how Cxbladder test results impacted a patient outcome, and to gain insight into healthcare providers' perspectives on clinical utility of Cxbladder. To start, we can discuss a specific patient of mine, and this is an 83-year-old male who initially presented to my clinic with gross hematuria in 2017. At that point, he was taken to the operating room and identified to have carcinoma in situ of the bladder, and he was initially treated with BCG induction, so once a week for 6 weeks, followed by maintenance for which completed a year in 2019. After that, the patient was followed by routine cystoscopy, urine cytologies, and occasional periodic upper tract imaging. The current status of the patient is that he is NED, but in this scenario, there is specific use for Cxbladder monitoring that I will discuss in a second. The clinical challenge was that the patient was doing well on surveillance until February of 2020. At that point, he came in for his routine cystoscopy, which on visualization was found to be negative, but his urine cytology actually showed malignant cells. So at this point, we did order a Cxbladder test, and it's specifically a Cx monitor. And as you can see here, the results on the screen, the patient actually came under the threshold, so he had a low probability of having a recurrent urothelial carcinoma. But following sort of traditional guidelines, the patient did go forward and was taken to the operating room, in which he had a negative random biopsies of the bladder and the prostatic urethra, and then selective cytologies from the upper tract were negative. He subsequently has had malignant cytologies, negative cystoscopies, and negative Cxbladder monitoring during his surveillance. His last evaluation was just recently, November of 2021, where he's still NED. At this point, his actually of interest is his cytology was actually found to be atypical, and his cytology was still negative. And so the other outcomes of the patient were that he did have upper tract imaging when his cytology converted to positive, which was negative. His other tests, like we just discussed, his random biopsies and prostatic biopsies were all negative, and his selective cytologies in the upper tract were all negative. This subsequently, it still holds true that his cystoscopies have been all negative, and his imaging, he did have one repeat CT scan, which was negative. So the interesting part of all this, that if we were to follow the Cxbladder monitor test, we would have not actually taken the patient to do any of these other extra tests. And so it's very important to have the ability to have a test with high sensitivity and negative predictive value. This will allow us for less invasive procedures for patients undergoing surveillance. And I think that this is a real critical key point that we need to understand, and really very important for our patients for the future.
Great, John. Thank you very much. So let me ask you a question. There was a question in the chat earlier about the use of Cxbladder after BCG. What's been your experience, and what do you recommend?
So just to, it's a great question. And to your point from previously with Dr. Goldfisher, I actually do cytology and Cxbladder on all the patients that come in. And I think that the important part is here giving them enough time. So post BCG, I think the majority of my patients have been fine with getting results back in from the Cxbladders, as long as they have had enough time from the last treatment, which is usually that 6-week cystoscopy that we try to do. So there is that sort of concern about getting inflammation and having inflammation in the urine, which can set off the Cxbladder a bit. But I really haven't found that to be the case post BCG all too often. So.
I agree. My experience is exactly the same, that you can use it in post-BCG, provided it's all about the inflammation, right? If there's too much inflammation, you're not going to get a test result, period. And so in those cases, you often have the same thing with cytology. You just have to wait. And most of the time, that's all it is. It's just BCG situs. So I noticed you'd order cytology on this case. Do you order cytology on it, use them together to adjudicate one? So what's your cytology use? So
to the point of quote unquote guidelines, and I know they're just guidelines, and I tried to stay traditional to the guidelines as much as I could. So because cytology is on the guidelines, I traditionally would order both tests. But honestly, now I'm actually going further away from cytology and actually using the home test a little bit more. So I feel more confident knowing now, with the experience and having all the tests that the data from all the tests that I've performed, where I will send a home test prior to the patient's visits and so forth. And if I get a result that I'm happy with, I will actually skip a cysto and just take the patient straight to the OR if it's positive, in office cysto. And then if it's negative, maybe do an office cysto depending on the risk stratification of the patient, how long it's been since their last cysto follow-up, et cetera. So I'm actually modifying a bit the guidelines based on the clinical scenario and clinical presentation of the patient, plus what CX is telling me. Can't hear you. Can't hear you.
Sorry, I was muted the whole time.
Yeah.
So let's say you have a scenario where you're doing the cystoscopy in the clinic and you see some red patches, and it comes back and the cytology comes back atypical. Patient's already home, right? This is 2-3 days later. What's your algorithm? What bring them back? Do you send them a home test? What do you do in that setting?
I've definitely been using more of the home tests. I think, that's a huge sort of, in New York, we do have some travel. I do get patients to travel 1 or 2 hours. But, 1 or 2, 1 mile for us is the same as 100 miles in the Midwest. Sorry, Katie. So it takes about the same amount of time. So we, I think the convenience of the home test is huge. So I have actually been more relying on the home test and setting up the home test. And I've actually come up with this sort of an algorithm with my office staff about, trying to get these home tests before they even come into their visits. I think that you made the comment a little before. I think the biggest improvement I feel like we can make for these patients is actually minimizing the number of cystoscopies they have to do in the office. I think psychologically that's huge for them. And I also think that repeated cystoscopies, we don't see it often, but the iatrogenic effects of strictures and some, bleeding and so forth, it happens, even after just a routine office cystoscopy. I've had patients come in clot retention because their prostate is just, massive. So if we can minimize how much office cystoscopy we can do, I think that's going to be really beneficial. And this is what I'm trying to sort of shift the practice to, using this home test to be able to maybe avoid a cysto or just go straight to the OR because it's positive. And I would want to do random biopsies or do selective cytology or do something anyway. So.
Great, John. Thank you. So Evan, are you there still? Let me ask you. You gave a great presentation on adjudicating atypical cytology. So what are you doing with these patients? So again, you're doing the cysto, and 2 days later, 3 days, however long it takes at your place, the cytology comes back and it's atypical. And for all intents and purposes, this bladder was absolutely normal. The patient's high risk though, so you do, worry about that. Do you bring them back for a blue light? Do you send them a home kit? What's your practice?
No, I would send them a home kit. Or in where I live in the Hudson Valley, our traffic's not quite as bad as it is on the Upper East Side. So patients can come back in and drop off a urine if they choose.
Got it. All right. So Katie, let me ask you. So let's do the opposite. You have cytology that comes back negative. Your cysto is negative, but your Cxbladder comes back positive. What are you going to do there?
Oh, well, that's a challenging one. I would probably, just bring that. I would first make sure I have some upper tract imaging, right? I'm going to do my routine, make sure I've covered all my other bases. I'd probably just bring that patient back for a repeat cystoscopy with enhanced cystoscopy, right? Whatever that may be in your practice. I would probably repeat a Cxbladder as well. Right now, I think one thing is inflammation. The hairs of they've had BCG, et cetera, we don't know what their past is. Usually that Cxbladder will come back inconclusive, right, with the inflammation or inflammatory changes. But my suspicion is going to be there, right, for that patient. I'm going to repeat a cysto and with some enhancement.
Do you think blue light is helpful in this setting? Perhaps bringing back for a blue light. Do you have blue light in the clinic?
I do not do blue light in our clinic setting, but I don't think it would be unreasonable, right, to be saying that you would take that patient to the operating room anyway for biopsies, potential selective cytologies.
Yeah, like the speakers here, I do exactly that. So if I have a negative white light, or if I'm doing blue light, if something is negative on endoscopy and I get a negative cytology and I get a positive CX, I just have a little bit more vigilance on that patient. I'll bring them back for a flex blue light, for instance, in the clinic a little bit sooner than I would, the 3 to 4 or 6 months later. If I have a typical cytology, absolutely, just like Evan and Katie and John are saying, and Kristen, I would then send a home kit. I just did that yesterday. The patient is many years out from a high-risk bladder cancer diagnosis, was treated with BCG and maintenance. He's 5 years out, a young patient, and his cytology, interestingly, suddenly came back atypical, absolutely pristine bladder. I was doing white light. So, I wasn't quite sure, and I'm going to let the Cxbladder sort of adjudicate, then I send him a home kit. So that's sort of the perfect scenario. And if that comes back positive, then I'll bring them back in for a flex blue light in the office to see if we are seeing any occult disease, perhaps. So, there are many uses for these tests for patients, for detection, for monitoring disease. And I think we've gotten a great overview from everyone on how to do this. And as John said, the home kit tests are absolute godsend at this time, and we're really we get these results back, and it's great to have it adjudicate these cytologies that can be unreliable, especially during this time. Just one last word. We're running into these situations where we now have flex blue lights and you have equivocal lesion. So you have an equivocal lesion where even the cytology comes back negative, does that cross the threshold of taking the patient to the OR? Older patients, again, COVID times, and what do we do with those patients? One of my goals in future sort of research endeavors is to decrease the false negative biopsies that we end up doing in the OR. The patients have to come off anticoagulation and pre-op, and it's a big deal. Go to the OR, and all this cost just to do these random biopsies that are very low yield usually. So one thing I'm doing is we've incorporated an algorithm in our clinic where if we have any equivocal lesion, we will send both cytology and CX at the same time. Like I said, we always have urine set aside, and then we will let that sort of adjudicate that suspicious or atypical finding on cystoscopy, because that happens often as well, where we have some erythema and we're not sure, whether this is CIS or not. So anyway, thank you to all the speakers. This was a great program, great discussion. I think we can go on for a long time. I wish this was live so we could see each other. But I think hopefully the audience got a great overview of the test. And if you have any questions, please feel free to reach out to any one of us who can answer some of the questions on use. We all have great experience with the test. So with that, I'll end my part of this presentation and turn it back to the AV folks. Thank you very much, everyone.
Thank you. That concludes our presentation. Have a good evening.